Bismillahirrahmanirrahim. This is half of the faith. This is the hadith by Prophet Muhammad sallallahu alaihi wasallam. Uh, Today the topic is Helicobacter pylori and gastric cancer. We will discuss the public health perspective. My name is Dr. Aamna Khalid. I am PGR Community Medicine, and I will be presenting this topic under the kind supervision of Professor Dr. Saira Afsal, who is Dean Institute of Public Health. So, learning objectives of today's presentation are we will understand the epidemiology of H. pylori and the gastric cancer, the pathogenesis and risk factors, the public health burden and disparities, prevention, screening, and control strategies. We will highlight the challenges in LMICs, the global distribution, progression of the infection to malignancy, and different public health perspectives. We will start with the introduction of H. pylori. This is this is a gram-negative spiral-shaped bacteria, and this shape allows penetration through gastric mucus layer. The bacteria colonizes the gastric mucosa, primarily inhabits the protective stomach lining. It's a major cause of chronic gastritis and peptic ulcer disease. The persistent infection leads to the long-term mucosal damage and is strongly linked to the gastric cancer. This is a key etiological factor in the gastric carcinogenesis. So some facts about H. pylori are that it was discovered by Marshall and Warren in 1982. Again, the shape is spiral or helical. The habitat is gastric mucosa, and it uses oxygen, so microaerophilic. And according to the International Cancer Research Organization, it is classified as a group 1 carcinogen, which is definitely a carcinogen. This is the natural history. And first of all, it invades into the normal mucosa. Then it's converted into gastric chronic gastritis. Then it is converted into atrophic gastritis. Then the intestinal metaplasia occurs, which is then converted into dysplasia, and then the gastric adenocarcinoma occurs. So infection takes about 20 to 40 years for conversion into a cancer. So this time period offers a critical window for intervention. H. pylori infection drives every step of this cascade, and the eradication of the bacteria interrupts the progression into further steps. So this is the global epidemiology of the bacteria first, that its prevalence varies by the socioeconomic conditions, and the distribution is driven by the sanitation and living standards. There is more than 70% prevalence even in the developing countries, and the high prevalence is linked to the poor sanitation and overcrowding. But in the developed countries, the prevalence is noted to be less than 40%. And again, the reason is improved hygiene and sanitation, which reduces the transmission. And infection typically is acquired in the childhood. Most individuals remain chronically infected lifelong. So the high risk groups include the low socioeconomic status people with limited resources. This increase the exposure risk. Then the overcrowded settings, the close contact facilitates transmission. Poor sanitation access, the contaminated water and food sources. And in developing countries, again, the prevalence is often more than 70% even. So this is the epidemiology of gastric cancer, that the high incidence reflects the environmental and lifestyle factors. The geographic variation across regions is substantial. For example, the East Asian countries are more affected, like Japan, Korea, China, and the highest incidence rate are noted in these countries globally. And then Eastern Europe, they have the dietary habits and smoking, which contribute to the elevated risk. In Latin America, the infection prevalence and healthcare disparities play a role, and there is low incidence in North America and Australia. This may reflect the protective factors or the relative underreporting in African regions. The right sided pictures again shows that East Asian regions are very highly affected, and Eastern Europe has high incidence, Latin America has moderate to high incidence, and North America has the low incidence of H. pylori and the gastric cancer. So now we come to the pathogenesis that the chronic inflammation is triggered by the H. pylori, and the continuous tissue injury and repair cycles damage the mucosa. Then the second thing is the DNA damage accumulates. The accumulation of the mutations promotes cancer development. There are some virulence factors like CAG-A, um, which is strongly associated with increased gastric cancer risk. And another virulence factor is VAC-A, which induces the cell injury and disrupts the immune responses. So combined carcinogenesis is actually due to the interaction of the host bacteria and the environmental factors. So on the right side, some virulence factors are shown, like CAG-A, VAC-A, BAB-A, and YPA. The transmission routes are important to be noted. First of all, we have the fecal-oral route, means by contaminated food and water. Then the oral route, which means that the bacteria spreads through saliva and close contact. Then the contaminated water, the unsafe water, which is a major contributor of the disease in low middle income countries. Then the poor hygiene, which is the lack of sanitation, which increases the risk. So addressing the transmission requires improvement in the wash strategies, the water, sanitation, and hygiene. So this is again a repetition in the pictorial form of the roots of the H. pylori infection, which is gastro-oral, oral. They have also mentioned the breastfeeding and latrogenic transmission, zoonotic transmission, food ingestion, water ingestion, and fecal-oral transmission. Now we come to the risk factors. If we focus on the host factors, then the genetic predisposition, advancing age, and immunosuppression are the factors leading to the disease. Environmental factors which are under our control, which may be dietary and habitual, like taking high salt diet, smoking, low fruit or vegetable intake, and alcohol use. All of these are preventable. Then the infection, the persistent H. pylori infection, the CAG-A positive strains, and the delayed eradication. So this is also under our control in a sense that we should go for early detection and prompt treatment of the infection once it has occurred. These are the social determinants of health. Poverty, which limits the access to clean water and healthcare, overcrowding, poor sanitation, and limited healthcare access, which delays the diagnosis and treatment. So, H. pylori is a powerful example of health inequity. The burden falls disproportionately on the disadvantaged populations. So, how to diagnose the infection? Uh, we have non-invasive tests, which is the preferred first-line test, which include the breath test, stool antigen, and serology. Then the second one is a urea breath test, which is the gold standard non-invasive test, which has excellent sensitivity and specificity for the active infection. Then the endoscopy with biopsy, which is invasive and provides a definitive diagnosis and histological assessment. Then the histopathology, which confirms the infection presence and any malignant change. Then the rapid urease test, RUT, which is a quick intraoperative test on biopsy specimens. Now we come to the treatment. We have two different types of eradication regimes. The first one is triple therapy, which is the first line therapy, which includes the proton pump inhibitors, clarithromycin, and amoxicillin or metronidazole. It is given to the patient for 14 days, and more than 90% efficacy is noted where resistance is low. Um, Quadruple therapy is used when clarithromycin resistance is suspected. So here we use the proton pump inhibitor. The second one is bismuth subsalicate, which is replacing clarithromycin, and then the metronidazole. So why addressing H. pylori is important because it is the fifth most common cancer, gastric cancer, which is caused by H. pylori. Globally, it's on the number five. On number fourth, if we talk about the leading cause of cancer death, and around 50% of the world population is infected at some point of their life, and it is classified as a group 1 carcinogen. Group 1 category means that it is the definite cause of carcinogen. So H. pylori infection is a major preventable driver of global cancer burden. So if we talk about the disease burden, the high morbidity and mortality is present worldwide. So the disease causes significant illness and death globally. The late diagnosis leads to poor diagnosis. So most patients present at advanced, unresectable stages. The healthcare cost, the treatment and hospitalization, the financial burdens, financially it burdens the patients, families, and the health systems, and the loss of productivity, which impacts individuals, families, and national economies. So around 1 million cases, new cases, are reported per year, and around 769,000 deaths are reported annually, and around 89% cases are attributable to the H. pylori, and the latency from infection to cancer is 20 to 40 years. This is the period where we can work for the prevention of progression to cancer. So this is the graph showing the stomach cancer death rate, and you can see that as we talked about the Japan, so this Japan shows the highest incidence since 1950s. Although the burden has reduced in the years till 2023, but still it has the highest rate worldwide. Then it is followed by Turkey, then Israel, Switzerland, France, UK, Canada, and you can see that United States has the lowest burden till now. So this is again a graphical picture showing the share of new cancers caused by H. pylori bacteria, and you can see that Pakistan has the share of 3%. And our neighboring country like India is also in the same color, means about 2 to 4%. Uh, but the regions like Afghanistan, Iran, if you see even the China, they have the higher burden. 6 to 8% is their color. So the public health significance is that it is a preventable cause of cancer. So early intervention is important, which can significantly reduce the disease incidence. And the long latency period is also an important thing to note, because the infection precedes disease by decades, and a window period is present where action can be taken. And opportunity for early intervention, screening, and treatment can interrupt the cascade of the infection. So how we can go for prevention? We have some screening strategies like test and treat approach, where we identify the infected individuals and treat them before complications has occurred. And the tests used are urea breath test, which detects the active infection non-invasively, which is a preferred method for screening purpose. The stool antigen test, which is useful for diagnosis as well, and a post-treatment confirmation. The serology, which detects the antibodies but cannot distinguish active from the past infection, and the endoscopy, where direct visualization and biopsy for high-risk cases is important. So the urea breath test is along with the stool antigen test and serology. These are non-invasive, and endoscopy is invasive. And endoscopy has definitely more accuracy than the other ones, and more cost than the other three tests. So the prevention strategies at three levels is discussed as the, if we talk about the primary prevention, then we have to improve the sanitation. Safe drinking water should be provided to the communities. Hygiene education should be given to the people, and we have to reduce the overcrowding. Then the secondary prevention level is where we use the test and treat program, and the screening high-risk group people. H. pylori eradication should be given properly to the patients, and early endoscopy if the infection is suspected. Then the tertiary level of prevention is we have to go for the early cancer diagnosis. The timely surgical and chemotherapy treatment, palliative care, and the rehabilitation services should be provided. The prevention of H. pylori infection, as we have already discussed, that no vaccine currently exists. So several behavioral strategies are important to reduce the risk of infection. These again include the hand hygiene, clean, safe water, consuming well-cooked and hygienically prepared food. This is important. Avoiding the sharing the utensils or the drinks, and improving public sanitation infrastructure as well. So one important thing is antibiotic resistance, which is a growing concern. This is a rising global concern where the resistance reduces effectiveness of the standard treatments, as we talked in the previous slide, that triple therapy is replaced by the quadruple therapy when clarithromycin is resistant. So the clarithromycin resistance is problematic because it exceeds 20% in many regions, compromising the first line therapy. And even the metronidazole resistance is also prevalent, especially in the developing countries. So there is a need for surveillance systems, and monitoring resistance trends is essential for treating the guidelines. And rational antibiotic stewardship is also important because this will prevent further development and spread of the resistance. So these are some of the challenges in low and middle income countries, that they have limited diagnostic facilities, which reduces the capacity for early detection of the infection and cancer. The high infection prevalence, even the infection rate is also high, more than 70%, which overwhelm the health systems. The poor health-seeking behavior, which delays the provision of health at the community level. The cost constraints, like the treatment, endoscopy, and the screening, which remains unaffordable for many people. Antibiotic resistance is a major problem where inadequate surveillance increases the treatment failure rates, and the weak health systems, like fragmented care pathways and the supply chain gaps, can delay the early detection and treatment and further steps. So, if we talk about Pakistan, the prevalence is more than 70%, as it's a part of LMIC. So, this reflects a widespread exposure in inadequate sanitation. Limited screening programs are there, which reduces the opportunities for early detection. There is need for awareness campaigns. We have to educate the public about H. pylori risk and prevention. And these are all about basically about the wash strategies, which will not only prevent H. pylori but many other fecal-oral transmitted infections. Primary care integration is essential. The test and treat approach is feasible at primary care level. The policy prioritization is required, where gastric cancer prevention must enter the national health agenda. So the recommendations are, we have to integrate the H. pylori testing in primary healthcare, mass health literacy campaigns, these are very important, and strengthen the WASH infrastructure, national cancer registry data, as we don't have it right now uh, in a proper form. Training of healthcare workers is also important. So if we talk about the role of public health professionals, then they can play their role in surveillance, monitoring the disease trend, resistant patterns, and the population risk. Health education, promote the preventive behaviors and community awareness campaigns. Policy making, to develop the evidence-based guidelines and national intervention plans, and the program implementation to ensure the effective execution of screening and treatment strategies. So these are some of the WHO strategies and future directions. WHO currently is working on the cancer prevention and control programs, infection control, and the WASH strategies, health promotion and education, and access to essential medicines. And the future directions are that there are multiple clinical trials underway for the vaccine development, and there are trials which are done on the mice currently. Better point of care diagnostics, which are affordable and accurate tools, especially for the LMIC where the burden is higher. Targeted population screening, which focus on the highest risk groups. The precision of personalized medicine, so tailoring the treatment to individual risk profiles, especially taking AMR in perspective. So this is the article published in previous year 2025 in May, which is on the development of a recombinant outer membrane vesicle based vaccine against H. pylori infection in mice. They say that we revealed that this OMV means outer membrane vesicle based recombinant vaccine candidate could induce specific humoral immune responses and helper T1, 2, or 17 mixed immune response with helper T cell 17 being predominant and markedly protect the mice from H. pylori infection. Our findings suggest that OMVs with a genetically engineered um, lipopolysaccharides may function as a vector for delivering recombinant antigens and safe adjuvants for the development of novel vaccine candidates against H. pylori infections. So now we conclude the topic with the remarks that gastric cancer is largely preventable through timely H. pylori eradication. Addressing H. pylori infection is central to any prevention strategy, and a multi-level approach is required. We have to focus on the individual level and the community level and the policy making, and equity in prevention and treatment must be prioritized. So prevention, early detection, and equity. These are the cornerstones of gastric cancer control. Now we come to the practice of MCQs. Question number one is a 45-year-old man from a low-income rural area presents with chronic dyspepsia. He has a history of overcrowded living conditions and poor sanitation, which is the most likely mode of transmission of his infection. Option A,
C.
airborne,
Sorry.
B, vector-borne, C, fecal-oral, D, blood transfusion, and E, sexual transmission.
C.
Yes, C is the right answer. Question number two, a public health team is planning an intervention to reduce H. pylori infection in a slum population, which is the most effective primary prevention strategy. Option A, chemotherapy, B, endoscopy, C, antibiotic prophylaxis, D, improve the sanitation, and E, radiotherapy.
D.
Yes, D is the right answer. Question number three, a patient is diagnosed with H. pylori infection and started on triple therapy. Which combination is most appropriate? Option A, antibiotic with steroid and analgesic. Option B, PPI with clarithromycin and amoxicillin. Option C, insulin with metformin and statin. Option D, antiviral with antifungal and an antibiotic. And option E, PPI alone.
B.
Yes, B is the right answer. Question number four, a screening test is needed to detect active H. pylori infection non-invasively. Which is the best option? Option A, MRI, B, CT scan, C, urea breath test, D, X-ray, and E, ECG.
C.
Yes, C is the right answer. Question number five. A patient treated for H. pylori does not respond to therapy due to antibiotic resistance. What is the next best step? Option A, stop the treatment. Option B, increase dose of same drugs. Option C, switch to quadruple therapy. Option D, no further treatment. And option E, surgery.
C.
C is the right answer. Question number six. A child in a crowded household acquires H. pylori infection early in life. What is the most likely outcome if untreated? Option A, immediate cancer. B, acute liver failure. C, chronic lifelong infection. D, instant recovery. And E, brain infection.
C.
Yes, C is the right answer. Question number seven. A global health agency classifies H. pylori as a carcinogen. Which organization made this classification? Option A, UNICEF. B, International Agency for Research on Cancer. C, Red Cross. D, FDA. And option E, World Bank.
B.
Yes, B is the right answer. Question number eight. A nutrition program is introduced to reduce gastric cancer risk. Which dietary modification is most protective? Option A, increase the salt intake. B, increase smoked food. C, increase fruits and vegetables. D, increase processed meat. And E, reduce water intake.
C.
Yes, C is the right answer. Question number nine. A 52-year-old man with chronic H. pylori infection undergoes biopsy showing atrophic gastritis. Which public health level of prevention is this stage most relevant to? Option A, primordial prevention, B, primary, C, secondary, D, tertiary, and E, quaternary prevention.
C, secondary.
Yes, secondary prevention now. Question number 10. A patient with persistent dyspepsia undergoes a urea breath testing after completing the therapy. What is the purpose of this test? Option A, diagnose the cancer. B, confirm the eradication of infection. C, detect the antibodies. D, assess liver function. And E, measure gastric acid.
B.
Yes, B is the right answer. This is the answer key to all of the questions. This is the YouTube channel of IPH where this presentation will be uploaded. Thank you so much.
Thank you so much, Dr. Aamna. It was a very good presentation.
Thank you.